Welcome to everyone. First of all, I would like to thank my friend Alicia and Pablo and all my friends in the entire team. It's a really big pleasure for me to be here and share with you some my knowledge and my experience about the periodontal topics. And I come from Naples, and this is the landscape of my city. And I live in the south of Italy. My city is Naples. And first, I'm going to speak to you about two topics closely connected. One is a biofilm and the relationship between the biofilm and the perio patient in strict way in the stage 3 and 4 perio patient. So today we talk about periodontitis because it's one of the most frequent chronic disease in the world, and we know that the prevalence is near the 700 million of people worldwide, and we know that the prevalence is near the 40 years old, and at the 40 years, 50% of the population are affected and increased as the age increases. As well as the peak of the incident rate is near 40 years. So at the end of 2070, the best periodontal experts meet in Chicago, and from European Federation of Periodontology and the American Academy reviewed the scientific evidence and developed the new globally accepted classification. And within the new classification system, patient should be characterized using a simple matrix that describes the stage and the grade of disease, of the periodontal disease. About the stage, this is the stage we can define 4 stages: stage 1, stage 2, stage 3, and stage 4. And about the grade A, B, and C. The stage give us the precise information about disease severity and the complexity of management. And in stage 3 is advanced periodontitis with the destruction of periodontal tissue behind half of the tooth length. A limited amount of tooth less than 4. And we can find the presence of bifurcation and infrabony lesion are common. In stage 4, we have increased the severity and the complexity of the previous stage by an increased tooth loss more than 5 teeth. And we can find the presence of masticatory dysfunction, which usually require a complex multidisciplinary treatment beyond the periodontal treatment. All these aspects make the treatment at this stage very complex, and the surgical intervention are usually needed. About the grade provides supplemental information about the biological features of a disease, including history-based analysis of the rate of periodontitis progression, assessment of the risk of further progression, analysis of possible poor outcomes of treatment, and assessment of the risk that the disease or its treatment may negatively affect the patient's general health. So about the biofilm, what the features does it have? And we must remember that this is our enemy. And but let's understand how biofilm is organized. So this is a scanning microscope image from a paper from Marshall, Philip Marsh in 2005, and you can find different color. Each different color is represent a different species of bacteria, and from here we can already understand your state of complexity. The biofilm is a very complex microbial community that adhering to the surface of a tooth or any non-exfoliable hard material. And the biofilm is stratified under the calculus and under the cementus of the root. It's very important to understand this particular aspect because the most of therapeutic strategies will be influenced by the type, this kind of relationship. So the bacteria within the biofilm do not live as an independent entity, but rather as a community well coordinated and metabolically integrated. There is a real stratification, well organized. In the inner lane, we can find different species of bacteria respect the top of the layer. At the beginning, the nutriment comes from saliva, and after they comes from periodontal tissue. Now, after about 7 days, in 1 week, the bacterial flora moves in the direction of the gingival sulcus. And we can see that as the defect gets worse, the biofilm likewise go down into the defect. So, at the same time, when the oral environment changes, when the patient takes alcohol or smoke, we can change the ecology of the biofilm inside of the layer. And we know that there is a strictly correlation between the pocket depth and the bacterial species. We can have more red complex in the pocket. And this is an eye pictures on the left side from the dental lab of Dentaid Research Center. And we can find for the whole thickness, we can find a live bacterial. And after 2 weeks, the appearance can change. The plaque calcifies, and we can find dead bacterial on the top of the layer, and the alive bacterial in the inner layer. After more time, we can find only a calcified state free of live bacteria. This summarizing is the relationship between the type or kind of bacteria and their organization over time. Start from wall thickness with the alive bacterial, and then after 1 month you can find only the bacterial. Moreover, you know that the biofilm percent on the tooth surface, which only 25% of the oral cavity, and the biofilm represent the wall of mouth about 75 on the oral cavity. And at the same time, we know that biofilm formation occurred in 30 minutes when you can insert an implant, and after 7 days, we can have the same spaces in over the implant, like to can find on the root of the tooth. So. Now, why it's so important? Now let's try to understand why it's so important in the etiopathogenetic mechanism of the biofilm. We know that the biofilm is necessary but not sufficient. And we know from a long time there is a cause-effect relationship between the aggregation of bacterial deposit and in the area of the gingival crevice from a paper Aran Law in 1965. At the same time, we know that there is a strict connection between the gingivitis and periodontitis. It's the same inflammatory disease. So after colonizing the bacteria, we have 2 possibilities. We have an acute response, and after that, one possibility leads to an active resolution of the acute response, and the second to lead at the worst solution. Therefore, the removal of the biofilm represents the fundamental phase of promoting healing. It's necessary to show to the patient how to remove the biofilm using an interdental toothbrush or or manual toothbrush. It's very important to understand, to explain to the patient how to remove the biofilm. And this is the complete case when it's everything go in the right way. But we can have a different patient, and the degree of the biofilm reduction to vary from the one patient to the next, because the patient can have a different profile, periodontal risk profile. The outcome of our therapy is move the patient with the high risk, periodontal high risk, in a situation with low risk. Because we can have a patient with the excessive host response. In this kind of the patient, in this kind, we can define susceptible patient, we can have an event of dysbiosis. We can have, we can find the microbiota inflammophilic, and we can have the pathobionts. So we can, after that, in patients with this type of impaired response, the accumulation of a biofilm can lead to a chronic lesion. This is the events. At the beginning, we have an health condition. We have a low of biomass diversity, and the bacteria are in symbiosis. After a few time, it can increase the biomass diversity, can start the initial dysbiosis, decrease the host response, and the clinical effect is a gingivitis or perimucositis. After that, we can have a more growth of biomass diversity. We can find the pathobionts. It's established the dysbiosis, the increase the microbiome virulence, and we can have a periodontitis or una periimplantitis, and we can have a periodontal touch and alveolar loss. And when happen, everything happened, we have an ecological catastrophe. And in Italian language, so we say a dog biting its tail, because everything starts with an alternated host response. We can have an overgrowth of pathobionts. We have a dysbiotic subgingival microbiome, and at the end, we have a dominance of periodontal pathogens. And this is the clinical aspect from a young woman with this kind of a problem, very, 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 very complex periodontal disease. We have very deep probing depth. We can have bleeding on probing. We can have pain. We can have a high mobility over the tooth. So, if you want to summarize this aspect, we have an insufficient immune fitness. We can have an aberrant host response. We can have two groups of a patient. One of these, the hyper-responsiveness and hypo-responsiveness. About the group with the hyper-responsiveness, we have PMN function affected by epigenetic. And in hypo-responsiveness, we have a PMN function affected by different problem, like to systemic disease, like the diabetes, or problems related to incorrect lifestyle, stress, smoking, vitamin C deficiency. And one of the things these patients have in common is this possibility of controlling the disease by reducing the biofilm. And this is very important to understand, because we know that the microorganisms present in the biofilm are more resistant to antibiotics and antimicrobials, and more or less 1,000 times greater than the planktonic bacteria. So About the biofilm removal, this strategy is performed from a clinician or dental hygienist and from the patient. About the professional plaque removal, it's important to follow a very precise sequence of therapy. This is a periodontal flow chart where probably the most important moment is represented by the causal therapy or non-surgical periodontal therapy. We know that this kind of procedures is, if well performed, may limit the need of other additional alternative treatment. And we know that with this kind of procedures, we can obtain a lot of closed pocket, near to 74%, and we can reduce the BOP. It's not very important how we want to approach. We can realize a full mouth approach or quadrant-wise, but we don't have any significant difference between the treatment group. At the same time, if we want to compare the hand or sonic ultrasonic instrument, no significant difference we observed between the treatment group at any point for the different category of initial pocket depth, about the PD reduction and the cal gain. Obviously, we don't always to obtain this result. There are some factors that influencing the outcome of a non-surgical periodontal treatment. And 3 different factors can influence the result. The smoke, if the patient smoke he has not good result. We prefer the patient with high plaque control, and the single root tooth can get a good result better than multi-rooted tooth, because it's very difficult to clean a molar or furcation of upper on lower molar. So now I want to explain this approach, non-surgical periodontal therapy, and I want to show you a woman, a young woman. She had a stage 3 and degree B of periodontitis. This was the aspect at the start of the non-surgical therapy. This was the aspect of lower jaw and the central incisor. Everything starts with a good diagnosis. We must to understand the degree of the compromise of the patient, and if for the tooth are an increased mobility, we generally we use a probe. It's important to understand how deep are the pocket. We can see at the same time calculus and the immature biofilm. We can see the status of the clinical aspect, edema, probing depth, very, very deep, bleeding or probing. And we can start we can start with the removal of the calculus using the ultrasonic devices, and using in very safe way the ultra thin tips with the ultrasonic devices on the supragingival area. In this with this approach, we reduce the edema, we reduce the amount of the bacterial with the slim with the ultra thin tips, into the interdental space on the buccal and on the lingual aspect. After that, if we have the different strategies, we can use the head polish outside and on the buccal side, on the subgingival and the supragingival aspect. And at the end of the professional therapy, it's very important to show at the patient how to use the instrument for home care control of a biofilm. Like that, we suggest at the patient the use of a interdental toothbrush from buccal to lingual and to lingual to buccal. It's very important to show at the patient how to use home prophylaxis tools like the interdental and manual or toothbrush. After 2 weeks, generally I check. It's very important in periodontology. There is no need to hurry. It's necessary to give the patient time to improve the home care suggestion and the tissue to be able to heal. If the patient at this step still have hypermobility, it's better going to splint with the steel wire and the composite, like this aspect. In general, in a complex case, I prefer to meet the patient after 1 month to check their ability to clean, and if it's necessary, to retract in very, very safe and in micro non-surgical strategies. We using the probe. We want to understand if there is the calculus, and then we remove in very safe way the calculus and the biofilm with the ultra thin tips on the ultrasonic devices. Generally, we use the microscope to obtain a good result. And when everything goes in the right way, we get to restore of the periodontal health. And this is the aspect we define as a healed but reduced the periodontal support. Namely, we have a good clinical condition, but it's very important to remember that we have the same risk of recurrence of periodontal disease. This is the aspect only at the 3 months with periodontal non-surgical strategies. This is what we can get with this kind of strategies. This is the aspect at the X-ray images. So we can have some patient like this young woman, 20 years old, and we had both periodontal and occlusal problems at the same time. The patient had periodontitis stage 4 grade C with severe periodontitis with the potential for loss of dentition, severe rate of progression. This was the aspect right side and the left side. One of the most complex sites was on the 2.4 premolar with high hypermobility due at the very occlusal stress. This was the probing depth On the right side, you can see the osseous defect, a vertical intraosseous defect. Even in this case, it's better to improve the final result, join the teeth with a splint to reduce the occlusal stress. And at the same case that before, we remove the biofilm sopra in the sub-gingival aspect. Even in this case, we use a very safe devices with the ultra thin tip on the buccal and on the lingual aspect. We remove the calculus like this in these images. It's better to use the microscope to see in a better way. We can use the tip with a different shape. If you want to, can use the micro curette to debridement the root. It's clear you can use the prophylaxis with the hair polish if you have. This time it's better to don't use because we have a lot of aerosol. It's better to use only manual devices. It's clear that the patient can probably clean the elements affected by periodontal disease, even if we have the splint. We show him how to use the interdental toothbrush. You see on the buccal aspect and on the lingual aspect. And after 3 months, you can observe the increase of the mineralization of periodontal tissue only with this kind of treatment, without surgery. On the left side, we can observe the difference between the beginning and at the end of non-surgical treatment. This aspect on the buccal aspect and the lingual aspect. We can see the different state of health of tissue. Very complex periodontal disease on the left side, and with the resolution of the clinical aspect on the right side. However, we don't forget that probably the most important reason to allow this result is strictly connected to oral hygiene instruction. Oral hygiene instruction is the most important thing, is knowing how to take care of yourself. In this phase, in this step, the dental hygiene plays a fundamental role because it's important that teach him how clean his mouth, and whenever he returns, the hygienist repeats the reinforcement and the motivation intervention. We know that the adequate personal oral hygiene can be considered even superior to that of the frequency of a maintenance visit. Everyone who come in the office, is very important to understand if the patient use in a correct way the different devices, the toothbrush, micro toothbrush on the lingual aspect. So, to improve this kind of the result, we can use some mechanical and chemical tools, and these devices can help the patient to perform a good plaque control. We know that the self-performed mechanical plaque control is the mainstay of prevention of periodontal disease. At the same time, you know that the interdental brushing in combination with the tooth brushing provide a significant reduction of both plaque and gingivitis score. And we have a better result if we use both the brush at the same time with the interdental brush. There is a lot of difference between if you want to use only toothbrush, we can clean only near to 60%. If you use a toothbrush and interdental brush, you can clean near the 100%. About the difference between the power-driven toothbrush and manual toothbrush, we know that it's more efficacy the power-driven toothbrush, 48% against 36%. And about the electric toothbrush, we have a new devices. We have a two action, a mechanical action and hydrodynamic action, and probably with the new sonic toothbrush we can have more efficiencies about the reducing the plaque and the gingivitis after long-term use. When we must to reduce the biofilm between in the interdental space, probably it's important to use the interdental brush, because interdental brush cleaning better than manual toothbrush. Even the use between the implant is better to use the interdental brush because it's possible to leave some pieces of floss near the color of the neck of the implant. This is very important to develop of a peri-implant disease. Then it's better to use the interdental brush in this kind of the patient. About the interdental brush, in general, those straight would be suitable for the aesthetic area, while those curved for posterior region areas. But generally, I prefer to use always for my patient the interproximal plus. I prefer this kind of shape. So at the beginning, it's better to recommend an undersized interdental brush, making it pass different times in every space. In every space, and it's necessary to have a long time to explain how to use this device, because this device is very important for the end of the results. So about the chemical substance, we know that the chemical agent represent an additional step in an individual oral hygiene regimen, and probably the most effective seems to be the mouthwashes. About the formulation, we can have a different chemical agent and a different concentration. We know that chlorhexidine is the gold standard for chemical plaque control, and if you use the chlorhexidine, we can have a better control of a plaque and less gingivitis compared to when we can use chlorhexidine. But if you use this kind of solution in erratic way, we can have a lot of side effect, like to bracket pigmentation, secondary increase of the formation of calculus, dysgeusia with a bitter taste, and the sporadic erosion of the oral mucosal membranes. And but the important concept is not to destroy as much possible the bacteria, because we risk the killing even the physiological one of the oral cavity. But we prefer to prevent the bacteria can become a community. We love this concept. Less is more. And we want to have something with the chemical control with high substantivity. And a genius, a few years ago, joined a crystal of cetylpyridinium chloride. Dr. Alberto Massoli come from Italy, and improving the efficacy of chlorhexidine without increasing the concentration. Thanks to reduce the with this synergic effect, we can increasing the antimicrobial activity of chlorhexidine and reduce the side effect, especially the taste. And in this way, we can obtain mouthwashes with the reduced concentration of chlorhexidine, and we have the same result from control of plaque index with to control with the chlorhexidine with more concentration of chlorhexidine. Is not significantly different between the two chemical agent. So, if you want to use the intensive care, it's necessary to use 10 milliliter for 30 seconds 2 times a day. Instead, if you want to use the active control, it's necessary using more dose, 15 milliliters for 16 seconds, 1 minute, 2 times a day. Generally, I prefer to prescribe intensive care during the early stage of therapy to take advantage for its bactericidal ability, and active control when I need to have a bacteriostatic action at the end of the periodontal therapy. So now I will end my report by showing you the treatment of 3 different cases with 3 complex stages of periodontitis. We can start with Gianluca. Gianluca was a young man, and she complained it was a diffuse gingival bleeding during home hygiene. This is the aspect at the start of therapy. A lot of pocket, 160, very low plaque control, 92 sites with positive plaque, no other problem. This was the aspect on the left side, the periodontal chart. On the right side, we can see the osseous defect, especially in front area. This was the periodontal risk assessment, like to high risk. He was a periodontitis stage 3, grade B, and everything started with reduce the biofilm on the supragingival aspect. If you have, we can use the hair polish. Today, I prefer to use the micro brush. It's better for reduce the aerosol system. After that, we can use the ultrasonic devices on the supra and the subgingival aspect using very slim type on the top of ultrasonic devices in very slow way, because it's necessary to remove in easy way the calculus and the biofilm without disrupt the gingival and the periodontal tissue. We can realize this approach, mini-invasive approach on the upper and then the lower side. It's more difficult to remove the calculus when we have a thick biotip like this way. We have a very deep pocket, like to 10 millimeters in the different aspect. We use alternative, even both curette, micro curette, and the ultrasonic devices. This is the aspect after 3 months. Generally, we wait 3 months, and after we make the reevaluation, we have obtained a good result. This was the aspect after 3 months. Before, on the upper side, we can see the before state of disease, and the video show us the aspect at the end of a non-surgical therapy after 3 months. I could expect. Same way, we have obtained the good result on the lower side. On the right side, you can see at the beginning, and on the left side at the end of a non-surgical therapy. Change completely the aspect of the tissue. We can see there is pocket, there is the bleeding on probing. The aspect of the gingival tissue is better than before, and we have reduced the risk of a progression of periodontal disease. This was the aspect at the beginning on the left side. We had high profile. At the end of a therapy, of a periodontal therapy, we have changed the periodontal risk in a very low risk of progression of periodontal disease. The second clinical case is about Loredana. Is a young woman. Is a housewife. She has a problem with the aesthetic and functional aspect. At the beginning, we can see the aspect. He has two mother and a father with the problem with the periodontal problem. She has a secondary occlusal trauma. This was the aspect. On the left side, we can see the periodontal chart. On the right side, periodontal risk assessment. This was the aspect of the X-ray evaluation. The patient had stage 3 degree C. Even in this case, start with non-surgical periodontal therapy. This was the defect, very deep in the frontal area, with the pocket near to 10 millimeters between the two teeth. On the mesial aspect of 1 to 1 and 2 and 1, the same defect. Even this case start with the ultrasonic devices. We can use the micro curette to reduce, to remove the biofilm and the calculus without damages the periodontal marginal tissue. This was the aspect at the baseline, and after 3 months, the aspect of tissue. In reevaluation, we can obtain a good result. Respect the full mouth bleeding score and the plaque score. It was better than before, but there are a lot of pocket. It was necessary to go to the periodontal surgery, and two different kind of surgery. On the buccal aspect, I realize MIS surgical approach. In this case, I used a microsurgical blade. The interdental intercircular incision was extended to the buccal aspect of the two teeth next boring the defect, limiting as much as possible the mesodistal extension to allow the reflection on a very small full thickness place to expose 1 or 2 millimeters of the defect associated to residual bone crest. Generally, we prefer no vertical releasing incision. The defect were debrided with a combined use of a mini curette and a power drive instrument, and the root was carefully planed by the use of the curette. After that, care was taken to prevent any disruption of the papillary fibrous attachment to the bone crest and the crest associated root in order to preserve the stability of the papilla. At the end of the instrumentation, we use endogain plus bone substitute. And at the end, the single modified internal mattress suture was positioned at the defect using monofilament sutures and with this kind of approach can close in primary intention the defect. This is my post-surgical protocol. For 1 week, the patient used adoxycycline 1 tab two times a day for 1 week. The patient used a periodontal active control raising 3 times for a day, and weekly prophylaxis was prescribed. And the patient were requested to avoid brushing, flossing, and shaving in the treated area for 3-4 weeks. At the same time, on the lower side, between 3.5 and 3.6, it was a periodontal defect, a vertical defect. In this way, I use open flap debridement without the use of endogain, only debride the defect, remove the calculus, and to polish the root and the defect. We have obtained a good space to obtain a very stable coagulum. And this is the aspect at the baseline on the right side, and at 1 year after on the left side. And so after 6 months, you can start the orthodontic therapy. This is at the end of the movement of the tooth. This is the aspect in the left side at the beginning, and on the right side at the end of the therapy. I made the composite between the 2 central incisors to close the papilla. And this is the timeline. The time was 20 months between the baseline at the end of orthodontic therapy, and every 1 month the patient made the supportive periodontal trip every 1 month for 30 minutes. At the end of a therapy, the patient go in the periodontal support therapy support 1 hour every 3 months. In the final, we can see the aspect at the baseline at the post-orthodontic therapy at a control after 5 years. You can see the very stable periodontal tissue. It is very important to maintain this kind of health, thanks to recall of the patient in periodontal non-surgical maintenance, because it's very often we can happen recurrence of periodontal disease. And this was the smile at the end of the patient. This was the last cases. A woman, 43 years old. She has a very important occlusal instability. The diagnosis was a stage 4 degree B. She has a familiarity for periodontal disease. This was the Velus, very high the plaque control, no good bleeding score. She had a lot of periodontal periodontal pocket near to 100. This was the occlusal evaluation with a lot of masticatory dysfunction, secondary occlusal trauma, drifting, flaring, deep bite, clockwise canted upper frontal planar, and the upper molar over erupted. This was the aspect under the frontal area, the divergence plane. Very aesthetic, challenging. The treatment plan was start with the occlusal causal therapy, with the surgery, with the splint, and the orthodontic treatment. At the reevaluation, the aspect of the tissue was better but no good. Remain a lot of a pocket. Even in this case, I made a surgical approach with the intracircular incision with the microblade. I elevated the flap on the buccal area and exposed only 1 millimeter of a bone. I reflected in this case the papilla on the buccal, on the lingual aspect. To clean, the remove the granulation tissue between the root. This was the aspect of the papilla on the lingual aspect. I removed the granulation tissue in the interdental area. I removed the granulation tissue with the curette. This was the defect between before the treatment with the intraosseous lesion. I applied the Emdogain on the surface, and even in this case, I used a bone substitute to reduce the risk of recession at the end of therapy. Even in this case, I made a sutures with the monofilament, internal sutures modified by Laurel. This was the aspect. At the end of strategies. This was the aspect at the end of surgery. I made a splint to reduce the risk of hypermobility. It was the aspect at the beginning and after surgical therapy. After 6 months, on the lower side, I elevated the defect. This is the aspect after 1 year. It was the result after 6 months after post-surgery, and this is the full-mouth plaque score and the bleeding score at the end of surgical therapy, and now the patient can start with orthodontic treatment. This was the aspect at the end of the orthodontic therapy. My colleague Marino Mursili moved the tooth in the apical direction. This was the aspect at the beginning and at the end. We can show we can see the different aspect of the tissue and of the tooth. This is the different aspect of after the X-ray evaluation at the baseline, at 6 months and at 2 years. And this is the timeline. After 4 months, I made the surgery. After 1 month, it started the orthodontic treatment. After 6 months, it started the orthodontic treatment at the upper side, and at the end after 50 months. All the therapy during 26 months, and every 30 minutes, every 1 month, the periodontal come in the office to make a periodontal recall. And this was the aspect at the end, and the patient start with the periodontal supportive therapy 1 hour every 3 months. And this is the final aspect at the beginning, at the end, and the face of the patient at the beginning, at the end, and the new smile is very happy, the patient and also the clinician. So I finish. Thanks all for your attention. And if you want to have some question, you can send me an email, and I will answer you as soon as possible. Thank you. See you soon. Bye.